The next topic is outcomes measurement. For most of medicine, the best measure for the things that we do are the differences in outcome that we create. That would follow along with Ken Arrow's 1963 decree that in ideal insurance, patients would pay by the outcome. But can it be done? Outcomes collection is challenging, but a state that could put a man on the moon certainly can do this kind of technology. And it's been done before. In Michigan, they have a regional collaborative of hospitals and physicians, and they both cut costs and improve the quality of care. Complications from surgery dropped almost 2.6% among the Michigan hospitals, and the annual savings from this collaborative were approximately $20 million, far exceeding the cost of administering the program. This program was interesting because it was a hospital-based registry. Because of the unique situation of Michigan, where better than 60 or 70% of the market is controlled by Blue Cross Blue Shield, it was a single insurer paid system. It paid for itself with the savings generated. Decreased complications resulted, and it saved that state money. A subspecialty example, and this has the roots in the Institute of Medicine's Learning Healthcare System. They developed a prototype called Improve Care Now, and they're scaling it now to PedsNet. But in the Health Affairs article, they reported that the remission rates from children and youth with inflammatory bowel disease improved over time by the communication between the doctors using a registry that measured outcomes. This was multiple practices, but a subspecialty-based registry, with a single diagnosis in this example, and it made a measurable difference in less than 5 years. This is something that improved quality when doctors measured the outcomes of the treatments they provided. An orthopedic example is the MOON, the Multi-Center Orthopaedic Outcomes Network. They only looked at 2 diagnoses, ACL tears and rotator cuffs, but multiple academic medical centers took the time and the expense to collect the data that was done by their physicians and surgeons on ACL tears and rotator cuffs. This was all orthopedic. It was multiple practices. They only used 2 diagnoses, but they showed improving clinical care by using the outcome data that they generated. And it's been the source of multiple academic studies, too, that have added to our knowledge of these 2 diagnoses. A more simple example is the orthopedic trauma program at the University of Utah School of Medicine, where the doctors used a tool called PROMIS. And it was a computer adaptive test we'll talk a little bit about, but they measured just the lower extremity function in 4 questions, and they found that this was as good as most of the legacy tools that they had. But the technology exists for doctors to collect outcomes in their clinic if properly incentivized and motivated. It was a orthopedic trauma program, a single practice where they were measuring patient-reported outcomes in their routine practice of orthopedic care. Most experts agree that you'll need a general health outcome measure as well as a joint-specific or site-specific outcome measure. There are tools available that make this less difficult. PROMIS is one example. It's free to use. There are no licensing fees. It was developed by the NIH, and they created it for just this purpose, measuring outcomes. It's useful for nearly all diagnoses and treatments, and it allows comparison not only between orthopedic patients, but between orthopedic patients and other medical specialty patients. It's available in Spanish and other languages, and there are versions available for adult and pediatrics. I encourage everyone to learn as much as they can about this program because I think it's a valuable tool for us to try and use in the Texas Collaborative. An additional advantage to PROMIS is that there's a computer-aided testing or a computer adaptive testing version where there's less burden to the patient. By only asking 10 questions, you can get the same sort of metrics that you'd see from doing an SF-36. And while this probably means more to the bean counters, PROMIS is already SNOMED and LOINC compliant, which makes it easily adaptable for most any EMR. Every surgical patient would be a measured data point that matters for the studies. We would capture a score from the patient preoperatively and select a case-specific ICD-10 code. Risk-adjusting ICD-10 codes would also be selected, but these could be captured from the primary care doctor, from the insurance company notes themselves, or from a good H&P from the orthopedic surgeon. Finally, the exact CPT code for the surgery would be required, and at various intervals after surgery, an outcome measure would be recorded. The difference in the patient-reported health score after surgery compared to before surgery will give some delta on what difference the surgery actually made. The Dartmouth Atlas folks have done a great job of showing us the variation in Medicare case rates that actually get done. On the right side, you can see lumbar fusion is all over the map, but hip fractures are pretty reliably within the center. What it doesn't show are the variability in the outcomes that the patients experience, and this is by far much more important data. Noting the case rates that give our patients the best outcomes will tell us how best to spend our nation's money. The key message is that if we use our daily practice as something to create the big data in the context of a system where we can learn about it, we'll be able to apply that knowledge at the point of care, and that will help improve the health and lives of our patients. For more information on big data, see the July issue 2014 on using big data to transform care.